Thank you very much. I should point out that SIS is actually owned by the ASGBI rather than anybody else. The idea is that because it's owned by your professional organisation, it will always be here for you. This title is one that I sort of thought was a bit alarming when I first read it, but then when you actually look back at the history of medical manslaughter, that is both disturbing and alarming. So particularly for the people who've been involved in it. So perhaps it's not a bad way to sum up what this talk is all about. David Selous is someone who is well known, I'm sure, to the vast majority of you, and there was a great deal of shock when he was actually convicted of manslaughter, and then there was a custodial sentence of 2.5 years imposed. And we'll come back and touch on some of the facts around the Selous case in due course. But it's a mistake to think that it is a great rarity for surgeons and other doctors to be charged with medical manslaughter. So basically the thing to get your head round, and the lawyers are going to go into this in much more detail, I'm sure, later, is that what we're talking about is something where there is no intention to cause death or serious injury, but through recklessness or wanton disregard, death is caused. And we will then look a little bit more about how the courts try and distinguish between that, between conduct which warrants criminal prosecution and conduct which does not. There's a lot of similarity, in a sense, between ordinary common law garden, clinical negligence and manslaughter, because you start off saying that the defendant owed a duty of care, that there was a breach of that duty, but then the breach has to cause death, and the breach has to be gross, such disregard for the life and safety of others as to amount to a crime and to deserve punishment. And it's that whole concept of this being a criminal act and deserving of punishment, which I think makes this such a difficult issue for doctors to get to grips with. So, if we look at the history, well, doctors have been prosecuted for manslaughter for quite some time. The first case that I was able to find was 1795, and there's a Dr. Rayburn who was convicted in 1831. And if you actually look back a long way, the conviction rate for those prosecuted seems to have been around the sort of 25% mark. So although that's small consolation to anyone facing prosecution, they might have thought that the odds were in their favour. Now, more recently, it's difficult to obtain exact figures, but there is a general feeling that things have changed a bit. That there have been an increasing number of doctors who've been charged since 1990, and if you look at the GMC figures, you will see 31 doctors stood trial for manslaughter, and 11 of those were convicted. Now, looking back, there's a case in the 19th century, mid-19th century, of a Dr. Dickinson, and basically he was charged following the death of a woman, and the story was that he had attended her in the third stage of labour, and basically he was trying to remove the placenta and thought he'd done so, and what happened was that the removal was incomplete and the patient exsanguinated as a result. Now, the interesting thing about this is the way that the judge approached this at trial, obviously addressing a jury, and saying that if a man, grossly ignorant of his profession, treats a patient, and if during the treatment of a patient he be guilty of negligence or want of due caution, and if in consequence the patient die, then such a man is undoubtedly guilty of manslaughter. Now, as it happened, the degree or the negligence here was not found by the jury to be sufficiently severe, I suppose, for him to be convicted of manslaughter, and he was acquitted. Now, More recently, in 1992, we had the case of Dr. Adamoko. Dr. Adamoko was an anaesthetist, and this was a hospital in the south of England, and he was involved in anaesthetizing a patient, I think it was for a cataract operation. And during that operation, the endotracheal tube became detached from the ventilator, but this was not spotted. And as a result of that, the patient suffered severe cerebral hypoxia and subsequently died. Now, the prosecution proceeded on the basis that really there had been no adequate monitoring of this patient, and had there been monitoring, this would have been spotted and the patient would have been reconnected and this death averted. So this case resulted in his conviction, and this was a case that went all the way to the House of Lords because there was a concern about the fact that there was no clear guidance on what really amounted to medical manslaughter. And Lord Mackay of Clashfern was at that time the Lord Chancellor, and basically what he said was that in medical manslaughter cases, it's for the jury to consider whether the breach of duty amounted to gross negligence and was therefore a crime. That required the jury to consider whether the extent to which the doctor's conduct departed from the proper standard of care involving a risk of death to the patient was such that it should be judged criminal. So, having sought guidance from the highest court in the land as to what really amounted to medical manslaughter, you've now got what is a rather sort of circular definition, and that, basically if it's a crime, if it's serious enough to be viewed by the jury as a crime. And that, I think, is roughly where matters. No other case has actually gone to that, to the Supreme Court since then. So that was Adamoko. Now, what I wanted to do next was just actually look at some of the other cases to give you an idea of the variety of medical situations which can give rise to conduct resulting in a prosecution for manslaughter. Now, the first case of these is intrathecal vincristine. And we had, I suppose, a spate of these cases, and the two of them at least resulted in fairly major inquiries. So in this particular case, he was convicted and sentenced to 8 months in prison, which I believe was a suspended sentence, and the GMC imposed a 12-month suspension on his registration, which I think is very, very unusual in any manslaughter conviction. You would expect the GMC to say it's automatic erasure. The second of these cases is actually a surgical case, and so we've got Stephen Walker, and he's come across, he's got a liver tumour, and he's setting about excising this, and basically the patient suffers catastrophic blood loss, and that's because this is not what he expected to find in terms of its size and its proximity to the major vessels. And you'll see that he was convicted and he got a 21-month suspended prison sentence, and as you might expect, he was erased from the register. Stevenson, 6 times the required dose of diamorphine, and he was convicted and he got a 15-month suspended sentence, and then he was erased from the register. And then another one which seems very bizarre indeed, Cavalli, and in this case, diabetic ketoacidosis was misdiagnosed as depression. He pleaded guilty and was actually sentenced to 2.5 years, and he was actually given that custodial sentence. He served his time. He appealed against that unsuccessfully, and he too was erased from the register. I want to look at this case with you in much more detail, because I think it's very easy when you're looking at little headlines like that to say, well, how on earth could those lead to to manslaughter. But in this particular case, I think it's instructive to look at the chronology of events in some detail. So this gentleman is a consultant urologist, and a patient is admitted as an emergency. And it's thought that this patient has acute pyelonephritis, and basically is seen by a registrar and is put down for an ultrasound scan and antibiotics. So that's on the day of admission, and then on day 2, this patient is suffering from rigors and is first seen by Mr. Garg 24 hours after admission, and he changes the antibiotics. At 11 o'clock in the evening, he's back in the hospital, but he doesn't see the patient, but he does check the chart with the registrar and sees that there has been no ultrasound scan, and the patient's condition was described by the judge at this stage in his sentencing as being grossly substandard. So quite clearly this patient had deteriorated. So the following day, there are more rigors, and the ultrasound scan has not been completed. And so there is a call put through by the registrar, to the registrar, to see how the patient's getting on. And he's advised that the creatinine's up, the blood pressure's low, and so the advice is that she should have an ultrasound scan as soon as possible. Now, at that particular stage, he decided that he wouldn't go into hospital because he had a very difficult night and he didn't feel in a good state to go in. At 1:30, he does go in, and she's seen to be pyrexial. He wants to see the ultrasound scan and then reassess, and it's not until 4 o'clock in the afternoon that this ultrasound scan is undertaken and shows an obstructed right kidney. He then visits the ward, but did not see the patient, and decides that the patient should have a nephrostomy. The radiology department thought it would be best to wait until the next day and also to have a CT scan. So there was discussion going on with the radiologists. And then at 8:45 in the evening, there is a CT scan which shows a stone at the lower end of the ureter. So this was discussed with Mr. Garg, who said that this could wait until Monday. And so the patient is then seen again by the registrar. He's concerned about the fact she's got a tachycardia, pyrexia, low urine output, and low oxygen saturation. So, I mean, obviously this patient has now been in a poor condition really for some time. So we now come on to day 4, and as really bad luck would have it, this is a bank holiday Monday. So at 7:30 in the morning, the nurses are concerned because the blood pressure's dropped again. Someone who's already really quite severely ill is now getting worse. And then the registrar goes off duty and hands over to a locum and basically says there's a patient with a blocked kidney. And one of the things that you see time and time again in hospital cases of all sorts is that this handover, particularly where the people don't know each other very well, is often a crucial point in things going wrong. For those of you who read the chorus reports, which I would commend to you, you will see time and time again that this is an issue which arises. Anyway, so Mr. Garg called in and said he would not be attending. I misled you earlier when I said that he'd not come in the previous day. This is the time when he said he'd had a bad night. And so at 10 o'clock, this locum registrar says that the patient is fit for stenting and books theatre. Midday, he arrives. The patient is more unwell than he'd realised, and the CT showed the stone to be higher than reported. Stenting was not appropriate, and so back to the plan for nephrostomy. At 5 o'clock, the patient was returned to the ward. Pulse and respiratory rate increased. The oxygen saturation was down. She had a cardiac arrest, and the patient died. Now, that is a long and sorry tale. And I think it's very, very hard when you look at a case like that to say that, this was good care, because it clearly was not. Mr. Gerard was convicted of manslaughter, and he was given a 2-year custodial sentence. He appealed against that sentence, and the sentence was upheld, and he was then erased. Now, there is something which made life much more difficult for Mr. Gerard when he faced trial, and that was the fact that the medical records had actually been altered after the event, and as a result of that, it was seen to be very poor conduct on his part, and undoubtedly affected the way in which the judge viewed his case. He also completed a cremation certificate with inaccurate information. So when it went to appeal, you can see what was said, that the sentence imposed, making due allowance for all the mitigating features, was not manifestly excessive. And the mitigating features were largely the fact that to that date he had had a totally unblemished career. He had not actually run into any regulatory problem of any sort. So there you have the detailed account of one case that led to a surgeon being charged and convicted of manslaughter. We started off with David Selous, and we'll just go back to that, because I think the David Selous case was the one that really started a great deal of concern about the whole concept of medical manslaughter and the idea of a senior surgeon being sent to prison when there had been no intention to do any harm. So basically, this is a patient who had a total knee replacement and had post-operative abdominal pain, and he was then asked to go and see the patient. There was a delay in the treatment of a perforated bowel, and the patient died during the laparotomy. And he too was convicted and given a 2.5-year custodial sentence. And it's important to note again the comments of the judge in sentencing, that there was no single isolated, it was not a single isolated act of negligence. And then, importantly, the witness statements to the hospital and the coroner contain numerous errors, all of them put you in a better light, and that there had been a lack of candour with those investigating the death. And so, in this case, as in the Gerard case, there is perhaps evidence of conduct which was totally wrong and resulted in a more severe view being taken or a more severe sentence being passed than might otherwise have been the case. And that might well be an issue that we explore a little bit later on. So that really is what I wanted to do to set the scene so that the other two speakers in this session can actually talk in more depth about the legal approach to these issues, and hopefully will give us the basis for a very lively debate in the final part of the session. Thank you very much.